Now it's my great pleasure to introduce the second speaker, Goran Zangana. Goran is a PhD candidate at the Global Health Unit in the University of Denver. Yeah, please. Yeah. Sure, yeah.
Does everyone hear me? Yes. Perfect. As I said, my name is Goran. I'm a PhD candidate at the University of Edinburgh. This research that I'm going to present about is not part of my PhD, but it was me functioning as a program manager with an international organization. And I mean, let me congratulate the organizers of this symposium, because in terms of the tremendous logistics of getting us all to here, it seems that they are doing a great job in also organizing the presentations one after the other. I think my presentation is providing a good case example of to apply some of the skepticism and criticism about RCTs and the biomedical approach to health in general and also mental health in particular. This is a randomized controlled trial that was done in, by the way, I'm from Kurdistan, northern Iraq, and I'm from there, did all my education there, my PhD is in the UK. And I'm working with Johns Hopkins University as part of this research. So it probably goes without saying that survivors of systemic violence suffer from all of these problems: PTSD, depression, generalized anxiety, other mental distresses, and also physical health problems. It's unfortunate that we don't have a very strong evidence base, particularly in the region, let alone the Middle East, probably all over the world. Yeah, so we don't have a very strong evidence base in the region. We have only 11 RCTs related to psychotherapy for torture survivors. 5 of those RCTs in low and middle income countries, and only 1 in the MENA region. And most of these RCTs were about psychotherapy, which are delivered outside the context of the survivors or the victims, mostly refugees or IDPs in different other countries. And those interventions, particularly CBT and RT, were developed or provided in different contexts than the survivors own. Kurdistan region of Iraq, where I'm from, suffered what Rita described really very nicely, or beautifully this morning, as descending of violence into the ordinary or the normality. The Saddam Hussein regime, particularly during the 80s and the early 90s, conducted a genocide campaign, which called the Enfal, resulted in the death of in the region of 50,000 to 100,000. There are estimates about that. Some say 182,000 actually. In addition to that, there was a chemical weapon attack in 1988 against the village or the city of Halabja, killing 5,000 people in minutes. In addition to that, bombing, forced displacement, arbitrary imprisonment, and torture, in addition to mass killing, happened particularly in the 80s and the early 90s. Our study took place in the two governorates of this is not working. Anyway, the two governorates in the southeast of the northern Iraqi region of Kurdistan, the Sulaymaniyah and Erbil. We excluded both things. We excluded the governorate, the Pope, for reasons that maybe if I have time will come to later. The study they took place in Erbil and Sulaymaniyah. The objective of the study was to assess the acceptability, feasibility, and effectiveness of scalable mental health intervention. Again, so I'm going back to James' point about scalable mental health interventions that are mostly developed in a Western context. So the methods, we did a 3-arm RCT. We tested therapy called CBT, cognitive processing therapy, another one called behavioral activation treatment for depression, and compared to the waitlist control. The CBT is mainly dealing with the cognitive sides of the client's trauma. So there's a trauma narrative involved that goes over the story of the trauma, and then we find what we call step points, or points in the thinking of the client that identify extreme thoughts or rigid thoughts that need to be dealt with. Again, need to be dealt with in the Western sense. The other arm of therapy, which is behavioral activation, mainly dealt with depression. They try to activate, as if we can say, the client and try to get the client back to the activities that they used to enjoy before the trauma. They are both 12 sessions therapy, so weekly sessions of 12 sessions, so they took between 3 and 5 months ideally. We developed this, or adopted this model of training. US-based trainers trained 20 what we call community mental health workers over 2 weeks. These community mental health workers didn't have any background or limited background in mental health. They were health workers trained in maternal, child health, or other public health disciplines. They were trained in these two psychotherapy interventions, and importantly, they were randomized to these techniques. Again, as part of the training, we also trained supervisors. The supervisors were trained in the psychotherapy itself and also in techniques of supervision. So they were trained as part of the training. These supervisors supervised the 20 CMHWs and then reported to the trainers through Skype calls that happened over a weekly basis. The instrument, the important point here, I think this is an area of debate. We tried to adapt it to the local context. It wasn't translated as it is to Kurdish. But rather, we did conduct a qualitative study. I wasn't part of that qualitative study, but a brief qualitative study was conducted before the study that enrolled 100, that was also for the reliability and validity test. About 128 persons were enrolled, and the qualitative study was conducted. And based on that qualitative study, 2 or 3 instruments, the Hopkins Symptom Checklist for Depression and Anxiety, a Harvard Trauma Questionnaire, and the Inventory for Traumatic Grief were adapted based on the information that we got from the qualitative study. So 13 locally relevant questions were added, and the instrument, as probably we have mentioned this morning, measured the prior 2-week symptoms of depression, anxiety, post-traumatic stress, traumatic grief. And we also had locally developed function scales for different or separate for men and women. Again, the instrument was tested for reliability and validity, and they were tested among local trauma or torture survivors. The eligibility of the study were the person should have been, the recruitment had been 2009 and 2010, May to June. This should be a survivor of systematic violence, living in the governance of Suleymaniye or Erbil, aged 18 or over, fluent in Sorani Kurdish, reported significant depression symptoms, had no current psychotic symptoms or active suicidality. For those who had active suicidality, we had a specific component for safety. For those with active psychotic symptoms, we excluded because the CPT, particularly the CPT arm, involved a specific cognitive component that needed clarity. Those who appeared mentally competent to consent and had a total symptom score of 20, at least 20 for depression. We did a randomization at 2 levels. I mentioned the first randomization at the CMHW level. We randomized the therapy, or randomized the CMHWs to therapy. Also, we randomized the participants to therapy. So the CMHWs, or community mental health workers who have been trained, obtained informed verbal consent from the participants, or from the potential participants. They explained to the participants that they will be randomized to either CPT, the cognitive processing therapy, or behavioral activation. And if the person agreed, then there was an envelope or a sealed envelope at the back of the consent form that was then revealing the therapy that the person was getting. Of course, important to say here that the person once revealed which therapy he or she was getting, that defeated the concept of randomization based on the person. So the concept of blinding the participant to the therapy, that the person knew which therapy he or she was getting. So this is a very detailed graph. I'm not going to go into all of these details. Okay, we enrolled 114, which were included in the intent to treat analysis for the VA or VATD arm. We enrolled 101 also in the CNT and 66 in the waiting list. I think I need to skip a lot of this because it's a lot of technical matters. What was striking to us, and this is important, also going back to the criticism of adapting some of these therapies and instruments to the realities and the context, to the local context, is some of these features were, this is the baseline. Of course, we did in the analysis bit, is mentioned very clearly, we did a pre and post assessment. We used the same assessment instrument for pre and post. And of course, the post-assessment, the pre-assessment was done by the CMHW who was providing the therapy, but the post-assessment was done by somebody else who didn't know which therapy or which CMHW provided the therapy. But some of this is the baseline characteristics that we found, and it was striking that there was a lot of illiteracy going on, especially among the trauma torture survivors. It's Iraq, we all know, it used to have a high literacy level, but unfortunately that seems to be going down. We had a lot of people who didn't read and write, and we had to use figures, graphs, pictures to depict some of the concepts or the complicated concepts such as dysfunction and function, etc. That was very interesting. Finally, I'm not going to go through all of this data. What is important here is that we found out in this, let me go to the conclusions. In this kind of research, we found out that it supported the effectiveness of this kind of psychotherapy for Iraq, or the context of northern Iraq or Kurdistan, particularly these two psychotherapy, CBT and VA. It was important that people without prior experience in mental health, community health workers, people who didn't have any background in mental health, could be trained in this complicated therapy to people, complicated therapy to some policymakers at the Ministry of Health, for example. And they could be adapted to the local level. And of course, there were challenges in terms of translation, and of course, there were challenges in terms of understanding some of the concepts. For example, I remember very clearly, self-esteem was very, very challenging to make clear to people. It didn't translate to Kurdish very, very well. It didn't translate in terms of meaning as well. So we had problems with illiterate participants. Stigma was very important in terms of people coming to sessions frequently. 12 sessions was too long for them. That affected their marriageability and also family reputation. We had a similar dropout rate. It was crucial. I think it's important to find it. We had a similar dropout rate to Western countries, which also you could argue that it was a positive finding. In terms of limitation, if I could go back, the follow-up occurred only within 1 month, and this was a problem of design of the research. We couldn't follow up these people longer, so we don't know basically what's the long-term impact, the treatment effects. The study design called for post-assessment 3 to 5 months because it was 12 sessions, but most of the times we ended up with an average follow-up time of 5.5 months because people were not coming regularly. We had to extend the follow-up time to 5.5 on average. Again, the participants were not blinded to the study. They knew what they are getting once that envelope, single envelope, is disclosed at the end of the consent process. And we don't know whether the effect or the impact or the difference between the intervention and the control was because just the people who are coming regularly to see somebody, talk to someone, or it was because of the therapy itself. we had 35 out of 232 people who were not blinded, but I think that was possible. We didn't conduct the sensitivity analysis that this showed that was not significant. In conclusion, I think this is a good case to kind of test some of the arguments. We were open to all kind of criticism in terms of translation, and I think we were trying to keep a healthy level of skepticism about it. But at the end, I should thank the whole team at Johns Hopkins Bloomberg School of Public Health, especially Dr. Paul Bolton, Judith Bass, and the rest of the team for conducting this research. I think the most important thing for us at the local level was training people who were not having anything in terms of mental health, to train them in the psychotherapy and trying to help social survivors. So thank you so much.
Thank you very much.